Hello, thanks for listening to the Total Knee Tips and Pearls podcast. This is Adam Rosen, your host. I'm a fellowship-trained orthopedic surgeon who specializes in joint replacement. In these episodes, I'm going to share with you a lot of my tips and tricks and review classic articles and current implant designs. Thanks for tuning in, and on with the show. Hello and welcome back. This is Adam Rosen, and you're listening to the Total Knee Tips and Pearls podcast. So today is going to be sort of the culmination of all of the previous surgical episodes, and I'm going to actually take the time to try to walk you through an entire case step by step. So although I may not go into some of the detail that I went into in some previous episodes about particular things, we're going to touch on a lot of those same topics, and I may bring up a few other little specifics just to keep your eye out. So with no further ado, so patient's asleep under anesthesia. The anesthesiology team is giving you the go-ahead. So first thing, again, examine the knee, both knees too. So whether or not they have a normal knee, arthritic knee, or replaced knee on the other side, you want to examine the knee that you're operating on. And for all intents and purposes today, we'll say that we're doing a right total knee. So examine it, extension, flexion, varus valgus, anterior, posterior. And then I always wrap it with web roll prior to putting up my upper thigh tourniquet, clear sticky U-drape. I use an Alvarado knee positioner. So I typically place this so I can bend my knee up to 90 degrees with the toes just inside the plate. So this is typically in line with the mid portion of the tibia for most patients. At this point, then the entire leg is prepped and draped, and our team wear full gowns, not just sterile gloves when they're doing their prep. At that point, then, first thing I do is actually put a down sheet down at the bottom of the table before we take the leg. Why? A lot of times as somebody grabs the leg, they have a habit of contaminating their bottom by hitting up against the edge of the table. So the first thing we always do is put a down sheet at the bottom of the table so the person holding the leg at the bottom of the table does not risk contaminating themselves. And then I always grab the leg around the calf with a sterile towel, and then the person that was prepping the leg then lets go. And then we place a impervious stockinette over the foot and then roll it up. The reason I do it that way is that even though the person that was prepping the leg put on sterile gloves, now that they've picked up the leg and they've manipulated, those gloves aren't sterile anymore. So if you put the stockinette on and it touches their hand, which is now dirty or contaminated, and then you roll the stockinette up, you potentially are moving contaminated stuff up the entire leg. At this point, I take the stockinette up, we put a U-drape up, put a bar drape across the top, and then I re-prep the knee with a small ChloraPrep and then roll the stockinette all the way up to the upper thigh. Then we place the extremity drape. I put the Alvarado boot on, co-band it, and then I use a little bump made with 8 towels that gets placed underneath the knee. And you'll notice that the knee moves very little as far as straightening and bending throughout the case. So at this point, it's got the 8 towel bump underneath it. I cut out just enough of the impervious stockinette to expose the knee and my initials that I've marked in the preoperative holding area. This way, you're limiting the amount of skin exposed, and then I make my mark. So first thing I'll do is actually mark the tibial spine on the co-band, and then the reason is that I want to touch the skin last, not touching the skin, and then make marks on my co-band, which potentially could take any skin bacteria that's left over and now put it on the outside of the drape. So I mark the tibial spine first, and then I will mark around the patella a couple little dots, mark my tibial tubercle, and then I make my incision straight up and down along the medial third of the patella. And then typically, my incisions with the bump in place, if I lay 2 of my fingers above the patella, make a line, 3 fingers below the patella, make a line. That's my typical incision length. But if I'm putting my fingers distally and I notice that I'm still above the tibia, I might switch that and do 1 above, 4 below. So I might adjust that based on the joint line or the patellar length and the patella height. So at this point, then we place an IO-band. Now, it's really important, I find, to place the IO-band down flat on the skin. I do not have a good explanation for why, if you make a straight line with your marking pen, and then when you put the IO-band on, it distorts it. If you follow that line, why the incision is then not straight. But what I do find is that if you lay the IO-band down flat and don't distort the line that you've made with your marking pen, and then you create that line, that will lead to straighter, more cosmetically appealing scars in the office. And then once the eye band goes down, so now we've closed off the skin, we all remove our outer drape. So I place our outer gloves. We place 3 gloves on at the beginning, so the top gloves come off after full draping, and then we manage all of our lines, do our official timeout. And then I typically, at this point, still use an S-mark and tourniquet inflation for all of my total knees. There are a few instances where I don't. So we do a towel over the eye band. It prevents the S-mark from slipping, inflate the tourniquet. Okay, now we move on to the approach. So make the approach with skin incisions performed with a 10 blade. Soon as that incision comes down, and again, we've talked about it, preferably one straight incision from top to bottom. And the depth you will learn with time, but you want to try to get down to the extensor mechanism. And then I will place the Z Richardson, which is my instrument that has a Z retractor on one side, Richardson blade on the other, so that gets pushed down just above the patella. And if you push down with force and lift up, a lot of times it strips all the tissue, so you have great exposure of the quadriceps tendon. And then also a Gelpi will get placed just above the patella. First assistant places 2 prongs or two-prong rakes medially. And then at this point, I will make my arthrotomy. I typically use the Bovie. Some people like to use a fresh 10 blade, but I use the Bovie typically on cut starting above. And again, I made a median parapatellar arthrotomy typically, so I'll come down. And as I come around the patella, my left index finger is on the medial border of the patella. So I know where the bone is, so I can leave an appropriate cup of tissue. And then as I come around, my first assistant is taking a fresh marking pen and marking the arthrotomy just above the patella. So we use that mark later when we close. Once I've come around the patella, my finger then slides to the tibial tubercle, so I know where that is, and I can continue my arthrotomy down with the cut. Once I get down below the patella, you find a lot more bleeders here. This is where I'll switch over to coag, and I try to pop the medial meniscus and then come directly onto the tibia in one straight line. And then at that point, I'll come back up proximally and see if there's any other bands of the arthrotomy that I need to release. Any bleeders that I see, I coagulate because the tourniquet's up. If they're bleeding, they're going to bleed more later. And then the Gelpi gets released and then dropped into the arthrotomy, opened. And then I always will then take the arthrotomy up another half to full centimeter. Why? Because I will find 90% of the time when you go to flex the knee up, that's what's tight, and then you chase that area. So when you do things repetitively over and over again, you try to find a more efficient way. And this, I find, is the efficient way of doing it. So I release superiorly. And then at that point, then the Richardson retractor comes out because I'm done up top. At this point, then the knee gets placed into slight varus, and I make my medial release. As soon as I release any remaining medial meniscus anterior horn, that pops, the 2-prong rake grabs the medial meniscus because under tension it'll release better, and I will initiate my release with the Bovie, being sure to make this full thickness down to bone and not creating railroad tracks. Now, depending on the person, the deformity will depend on how much or how little release, but I try to do a small release coming down, create that normal triangle from the tip apex of your arthrotomy on the bone. And then as that comes across, then I will switch over to the cob. And depending on what type of release I need, use the cob and strip a little bit more of the capsule away. And then with the cob still in place, once I've come around that corner, I will place a single point Homan between the cob and the bone, and then I can release any more tissue. So in a bad varus knee, this is where I might flex and externally rotate the knee some more and use the Bovie and release a little bit more medially or a little bit more posteriorly, and very little in a valgus knee. Valgus knee, I almost go right to the Homan and just release a few millimeters, essentially where the saw cut is going to come out, because you can all release that more. Now, if there are osteophytes medially, I will remove them off the tibia and remove them off the femur. And then at this point, the knee gets placed into extension. So the bump moves from the behind knee position to down to the ankle, and I will place my Z Navy retractor laterally and my Z Rich retractor medially. And now that I've worked medially, I work up superiorly and taking out that superior fat pad just enough for exposure, and coming down medially and laterally to where the chamfer cuts come out. Because if you take that synovium off now, that anterior chamfer bone comes out easy. If you leave that synovium attached, you have to tease that off when you do that bone cut later. And then next, then I move the Z-Rich medially. So the Richardson blade is medial to protect the soft tissue. And now I put the 2-prong rake laterally on the quadriceps tendon. And I use the Army or Navy blade, depending on what you want to call it, in between the patellar tendon and patellar fat pad distally. And then I will start proximally and take off any remaining synovium above the patella, coming down around the patella. The two-prong rake moves on to the bone now to stabilize it better. And I remove some of that inferior patellar fat pad, which is going to allow for exposure.
We'll be back after a quick break.
Once a person is triggered, there are biological changes that happen in the brain that zap your energy, motivation, and sense of pleasure. Now, that in itself is not depression until people get into the depressive loop. It's very easy for people to stop doing things.
Yeah.
And you get into what we call an avoidance pattern of behavior. You stop doing things that give you a sense of mastery and a sense of pleasure, right? And you withdraw because the brain's basically like, hey, if you're not going to do this stuff, then I'm not going to give you the chemistry you need to want to do it.
Yeah.
So the less you do, the less you feel like doing. The less you feel like doing, the less you do. Now you're in the loop.
And then all those retractors then come out. So then we move on to the patella. So I place two towel clips, one proximally in the quad tendon, one distally in the patellar tendon, and put those teeth down so they can evert and flip the patella up, and then release the tissue on the lateral aspect of the patella down to where you expect that saw blade to come out. And then a PCL retractor goes medially to stabilize the patella. And then I can measure the patella thickness either by hand or with calipers. And then I make my saw cut. So typically I'm aiming for that, 2 saw cuts, par 3 sort of analogy we've talked about before if you're freehanding it. So I like to flatten it and then get an assessment, medial, lateral, superior, distal, and determine what thickness I'm aiming for and making sure that I have a flat surface. So I'll finish that with the second cut if you need to with the third cut. If you choose to use one of the reaming guides or saw blade guides, do as you choose. But then at this point, then I size the patella and then drill the patella and place my patellar cover, which will be used for the rest of the case to protect the bone. And then those retractors get removed. And then at this point, I then flex the knee up. So this is the first time I've really flexed the knee up, and I'm aiming for 90 to 100 degrees of flexion. I place my Z rich retractor goes laterally, and the Z army goes medially. And then at this point, any remaining anterior horn and of the lateral meniscus and the ACL then get excised. A lot of times it may be absent already. And then I make my femoral drill hole. We've talked about on previous episodes the exact position and the drill hole in the tibia because I use IM on both. I open these up with a Charles-Lion just to open them up and to flute them and then dry them. Okay, so now on the femur, which I do second after the patella. So now I've used my intramedullary cutting guide. So depending on your system, you're going to set your millimeters of distal resection. And then typically I'll set for 5, but again, I may adjust this based on the patient or the deformity. And then I use 2 fixation pins. Again, we've talked about how important it is to place those pins in properly, and then a cross pin or an X pin. And then at this point, I remove the IM portion. And when we make our cut, the Z Richardson retractor moves over. So the Z Navy or Z Army has been left between the medial condyle and the MCL. And the Richardson blade comes over onto that soft tissue, this mobile window philosophy, and I am going to cut the medial aspect of the medial femoral condyle. If we've taken off those osteophytes before, 2 teeth blades essentially of the saw blade should come out, and then I work on the lateral aspect of the medial condyle, and then those retractors then get flipped and switched. So the Z of the Richardson blade goes laterally, and the Army or Navy blade of the Z goes up to protect the quadriceps tendon, where the saw blade's going to come out laterally, and then I move across and do the medial aspect of the lateral condyle and the lateral aspect of the lateral condyle, and then it jumps. And then the last thing I do then is move the other Z Army back over to the medial side, so then I have a somewhat good view of both condyles, and I can make one pass right down the middle. This allows me the ability to check and make sure that the cut is flat, and if I need to refreshen the medial or lateral side, I can, so I have a parallel cut. Again, if I'm looking for, depending on the system, the position related to the PCL, I'm looking for it to feather the PCL or to be slightly distal, depending on which implant company I'm using, and having an idea in your mind of, do I want to add more flexion or not, depending on the patient's anatomy and their bow. But at this point, then I recheck it with the alignment guide to make sure that if I was aiming for 5 degrees, that I achieved 5 degrees, and then those pins get pulled. At this point, then we do our sizing. So I have a special 2-piece sizer that we utilize. So I use a posterior referencing system, which is set for my rotation. So it's off the posterior condyles, and I can drill 2 holes, which sets my rotation. I need to adjust this depending on the person's anatomy, especially in a dysplastic lateral condyle or valgus knee where they've lost a lot of posterior cartilage. But you can use your white sides lines and epicondylar axis to set your rotation. And then I put my sizing guide into those holes, and then I can size. We use a little drill guide, which the drill will exit where the saw blade exits to let me know what size, and then I can use the appropriate size 4-in-1 cutting block that is necessary for the patient. So 4-in-1 cutting block gets on, pins get put in, and then my retractors then go up top. So I make my anterior cut, and again, I come out medially and then come across laterally to prevent these marginal fractures. And what I see a lot of times, depending on the system, though, is that, what you're going to see is this little sort of sulcus more when you take that anterior cut out. But when you come down, you're looking for that grand piano sort of sign, but getting an idea of what most anatomy looks like at each individual step, which will kind of cue you to say, hey, wait, stop if something looks off a little bit. So we've made our cut. And then what I do is then work medially and posteriorly. So once I've made my anterior cut, then my retractor is the Z retractor is protecting medially. I make my posterior medial cut, and then my posterior chamfer on the medial side. Then that Z retractor comes over to the lateral side, and then I make my lateral posterior cut, my lateral posterior chamfer, and then the retractor then goes up top, the rich on the medial side, because I will make my anterior chamfer, and I aim from the medial side, and then come across the lateral side, and then finish in the center area. And then at this point, then the 4-in-1 cutting block can be removed. And then you can remove the osteophytes if they're remaining, and the posterior condylar pieces. And then I tend to use my wide osteotome, which I find gets the posterior chamfer and the posterior condyles out well. And then this last little step that I'll do then is take the bovie around the edge of the femur, medially and laterally. And this is most important, I find, laterally, and most important in valgus knees, because a lot of times you're fooled after you make your cuts. You think that the bone has been prepared, but you're actually leaving a rim of bone. So by removing this, 1, you're removing the osteophytes. 2, you're improving exposure. 3, you're hopefully going to improve the balancing because that might have tented structures. So at this point, all of those femoral retractors come out, and then we move on to the tibia. So at this point for the tibia, I then flex the knee up a little bit more, so approximately 100 degrees. I do place a PCL retractor posteriorly, which subluxes the tibia forward a little bit. And then what I will do is release the posterior horn of the medial lateral meniscus, and then release the PCL off the tibia, essentially down to where you expect the saw to come out when you make your bone cut. So I don't really consider that a PCL release, because you're going to release it off the bone cut once you make it anyway. I'm just releasing it ahead of time. And then once I've done that, then I will take that PCL retractor out, pull the tibia forward, and then reset that PCL retractor, which allows me to expose the tibia forward. It subluxes it anteriorly a little bit more, but it better protects the PCL because it helps push that PCL down and out of the way for when that saw cut's going to come back into that area. And then I place a single pointed 90-degree Homan laterally. So on a right knee, this would be about 9 o'clock looking down on the clock face. And I put this just lateral to the meniscus. So my thumb typically is grabbing the patella, and then I'm popping it just lateral around the region of the lateral meniscocapsular junction. And then I can see quite well. Now, occasionally I'll start from the front, but if I can see the popliteus hiatus, a lot of times I'll start from that and work my way anteriorly, look for, and if you see that inferior geniculate branch bleeder or the lumen, make sure you buzz that. And then I will come around to the posterior horn and remove that. And then at this point, I will then relax that retractor because we're not working there laterally anymore, and then move over to the medial side. On the medial side, I place a 2-prong rake medially, and then expose the medial meniscus and start to excise that with the bovie. Once I get around and get the posterior horn out, I place a Homan there medially and remove the rake. At this point, now we have retractors medially, laterally, and posteriorly. I resuction the intramedullary canal, and then place my intramedullary alignment guide. First thing that I like to do is set my rotation. So again, we're looking at these visualized axis. Mainly I'm using the AP axis on the tibia, and again, using the PCL, using the tubercle, using any grooves that you might see as the patient's normal rotation. So all of those things get used together to set my rotation, and then that gets set with a drill guide in the set that I like to use. And then at this point, now I'm going to measure my resection, and I'm typically taking about 2 millimeters off the medial side in most varus knees, 4 to 6 on the medial side in most valgus knees. But I'm also using a landmark of that junction where the bone comes up and sort of that cartilage margin where the osteophytes would be, making sure that you're just below that. But this may be based on the patient's anatomy and based on the implant system that you're using. So once you've made your resection line, then we pin our block. And again, making sure that the pins go in parallel so it doesn't distort your block position. And then a cross pin or an X pin. And then my intramedullary guide gets removed. So at this point, then I work medially to laterally. So the saw cut will come in, and I will work on the medial aspect of the medial plateau again. So there's like a tooth or two of the saw blade coming out, preventing marginal fracture. You've removed those osteophytes before. And then the lateral aspect of the medial plateau, then centrally, making sure not to plunge because you don't want to injure the PCL if you're doing a cruciate retaining design. And then the medial aspect of the lateral plateau, and then lastly, the lateral aspect of the lateral plateau. And then you should see that tibial cut jump, and it lets you know that you're through everywhere. And then I will then grasp the bone cut and then pull that up. Any remaining soft tissue attachments we can remove. And then again, I will recheck the cut. So it's important here that you don't overly try to create posterior slope. And the posterior slope for me is fixed in the guide. So depending on the system that I'm using and depending on a PS or CR knee would dictate my slope. And at this point, then I'm going to repass that saw. Now, occasionally, if I dictate the slope based on the device, but as I'm cutting, and this is best appreciated, I think, from the opposite side of the table. But when you look at the saw blade and you look at the patient's natural slope, occasionally you'll see that blade will be off. So use that sometimes as a guide to take a little bit more slope if you're trying to recreate the person's natural anatomy. But I will make a last front to back pass centrally, because this allows me to assess medially, laterally, did I make a flat cut or was I high on one side versus the other? And then I can flatten that, remove the cross pin, remove the cutting guide, and then I use Dr. Caldwell's flatness assessor then to recheck it. Again, multiple checks to make sure that the cuts are as accurate as possible, and then we remove all of the tibial retractors. At this point, then I go to my posterior knee cleanup. So I suction the femoral canal, femoral lifter gets placed, it gets lifted up with my second assist, and I place a lamina spreader initially laterally, and then I will squeeze it. So it's like a kind of a poor man's tensioner. So I squeeze that with my hands, almost to feel your intrinsics fire, and I look and see, what that measured. These are calibrated lamina spreaders, and typically in the 20, 22, occasionally 25 range. But it gives me an idea of what that lateral side is like. The Army or Navy blade of my Z retractor goes medially, and then I will remove any remaining meniscus, and then I go after the posterior osteophyte. It's really good if you can see that cartilage margin on the bone and aim for that. You may take more or less depending on the person, deformity, and or laxity. And then again, for cruciate retaining design specifically, then you're also going in and you need to remove the intercondylar osteophyte that may even be hiding behind the PCL, because it can tent your PCL and tighten up your flexion gap. So at this point, once we've removed that, then my second assist lifts up again on the femoral lifter, take the lamina spreader out, flip it to the medial side, remove that Z retractor, and then place that Z Army on the lateral side. And I kind of tag this underneath the lateral femoral condyle so it stays, and then squeeze down on my lamina spreader. And again, using it till I feel sort of my intrinsics fire, and then looking to see those measurements pretty equal, or maybe slightly tighter on the medial side or slightly looser on the lateral side, but you're trying to make an equivalent flexion gap. And then again, remaining lateral meniscus gets removed, posterior osteophytes gets removed, and then if needed, if they had a significant flexion contracture and you suspected that you needed it, you can release posterior capsule at this point, and then all those instruments then get removed and the knee gets placed back into extension with the bump under the knee. Okay, this is where I do my first wash. We do a full 500 cc of pulsatile lavage wash. Helps me also visualize my extension gaps. We can check for any remaining osteophytes that may be left, any loose bodies, cleaning out any debris, especially underneath the quadriceps tendon, making sure that all the debris from that anterior cut has been removed. Once you go through 500 cc's, now my knee gets flexed back up. At this point, I'm flexing it up to 100, 110 degrees, and my tibial retractors go in. So the PCL retractors posteriorly. I then switch over now to a double-pronged 90-degree Homan laterally because I find that rotates or spins around less than the single point, and a single point Homan then gets placed medially. And this is where I size the tibia. So once I determine my tibia size, you want to set your rotation. And again, this had to begin earlier on in the case because you had the tibia still in place. You were using that with all the other landmarks to set your rotation, and that set the rotation of your cutting guide. So if you cut 3 or 5 or 7 degrees of slope, you've induced a certain plane. So you need to try to match that with the tibial cutting guide. Otherwise, you could be inducing, especially if your block was rotated medially and you cut medial to lateral, you may have induced valgus into your cut and not be aware of it now. So you want to make sure that you are aware of where the rotation was, set your rotation, and then place your pins or whatever you need to hold that in place and use your keel punching guide. Once that has been performed, be aware that you're flat, you're flush. And again, we've talked about this, that you don't want to be down on the soft side, be up on the hard sclerotic side, and then wail on that keel punch, because this is where you can induce a alignment change if you're not aware of what you're doing. So always try to make sure that it goes down parallel to the top of the tibia. And if it's getting hung up on the sclerotic side, stop it, back it back up. Occasionally, if I'm using the larger of the sizes of the keel punch and it's really hard, I'll go down to the smaller one first to make a smaller hole and then kind of size myself up. But just be aware as that goes down, and then that gets removed. And then we will then place our trials. We have separate trials that I will typically place into the tibia, place in my trial poly spacer, remove the retractors, drop the knee down to about 90 degrees, place my femoral trial, put it into extension, remove the patella cover, place the patella. Okay, now we're going to do our trialing. So again, I'm checking my extension to make sure that it's appropriate, that I have full extension, but it's not hyperextending and I don't have a flexion contracture. I'll check my varus valgus, both at full extension and 30 and 50 or 30 degrees of flexion, to make sure that I don't have any tightness in extension that's actually due to capsular tightness because I'm in slight hyperextension. Also checking my mid-flexion varus valgus stability, and then I'll flex the knee fully a few times to check my patellar tracking, but also check my full flexion. And then I will also check, if I'm using a cruciate retaining design, my PCL tightness, as well as my femoral tibial offset and my rollback, as well as what we've talked about in previous episodes, the idea of this combined rotation of what is the face of the distal femur in relation to the face of the tibia, and is that appropriate, and is it similar to what the patient had preoperatively? And at this point, this is where I may need to adjust by, if I'm loose, go up poly size. If I'm tight, do I need to release one side versus the other, or the posterior capsulars? Or is it tight enough that I need to do an additional bony resection? At this point, if I like everything, then I'm drilling my femur if it's a femoral implant that needs to be drilled. And then I am removing all of my trial inserts. Now, as the trial comes out, a poor man's sort of tensioner, orthosensory sort of device too is if I put the Homan in certain implants, you can put it right in the middle and then lift up. If you see it come up symmetrically, it means you're probably pretty well balanced, whether or not you check this inflection or extension or midflexion. Whereas if you see it's really popping out on the one side and it's being held up, the poly's sort of pivoting, say, on the medial side, but it wants to spin out real easy on the lateral side, that's a visual way of seeing, oh, they're probably looser laterally and tighter medially. So you can use what you can see as well as what you can feel to balance the knee well. But at this point, all the trial implants get removed, knee gets placed back into extension, and we do another 500 cc wash to clear out, again, any other debris, bone bits, feel around for any bone spurs, loose bodies. And then I will also go ahead and just prior to actual washing, place bone plugs in the tibia. And if there's sclerotic bone, we'll drill around the top of the tibia to open up that sclerotic bone, and then wash with the 500 cc's. Okay, implantation. So at this point, while we're washing, my tech is mixing the cement on the back table. Usually first and second assist are doing the knee and the washing and getting everything ready. And then primary is back at the Mayo, putting down a fresh towel, cleaning all of the retractors with a fresh lap sponge, and then opening up all the implants so they're on the Mayo, and then coming back up to the field. At this point, knee is flexed up. So for my CR knees, tibia first. So retractor PCL, retractor posteriorly, single point home in medially, two prong 90-degree home in laterally, making sure that the bone is as dry as possible, placing the cement in a slightly wet state on the metal on the Mayo stand, and when it's the appropriate consistency, then it gets placed into the canal, finger pack it, blood, fat's going to come up, re-dry the top of the tibia, place it on the tibia, finger pack it, impact the tibia, and again, don't squeeze with your hand and pull with your bicep and create anterior slope. Make sure it goes down parallel. Do not induce varus or valgus. Once it's down, clear out the cement, place your poly, reduce it. And then at this point, using your finger, if it's CR design, you can place it right into the notch as opposed to on the medial lateral condyle, but you can then lift up on the femur, flex the knee up, slide the tibia underneath. This is when I remove the retractors, and then the Z retractors get placed medially, and the rich goes up superior medially, and the Z goes laterally. And then again, for most knees, I do this by hand when we impact it, but otherwise, if it's a hard knee, I can have my tech at this point putting the actual femur on the handle. But then once the bone's dried again, cement gets placed all around the bone, a squirt or two up the canal, and then finger pack to get good cement interdigitation. The femur gets placed onto the femur, and then again, impacted, but making sure that it's going on appropriately. 4 things to look for if you're using pegged, the 2 pegs, and making sure the holes are lined up, and making sure your 2 posterior condyles are lined up, making sure that your femur is not flexed or extended. Once it goes on, then you can use your impactor, making sure that it goes down parallel, that you don't end the implant on one side and then wail on it, which could cause either soft bone to collapse or fracture. But once the bone is down, or once the implant's down on the bone, I will accentuate 1 or 2 hits medially, 1 or 2 hits laterally, and then 1 or 2 flat down again to make sure that we're totally down, and then remove the cement. At this point, retractors get removed, the knee goes into extension, and then again, tight knee, you really want to make sure that this goes down all the way, so you put a little force there. If they were a little loose knee, you want to make sure that you don't hyperextend. If it was soft bone, you don't want to compress the bone, so you have to alter the art of cementing based on the patient and their bone quality and their deformity and their ligamentous sort of support. But at this point, once I get into extension, then we're drying the patella, putting cement on the bone, putting the implant on, and then again squeezing it down. Hopefully you had a flat cut, but again, if your cut was a little beveled, you don't want to over squeeze the clamp because you're going to get the plastic to bend, and then when you let go, it's going to snap back and you're going to have a gap there. And then clearing out the cement and making sure that I like to hold this really till that cement starts to get hard and tacky. I don't like to flex and extend and varus and valgus while that cement's soft and hardening. So at this point, we've gotten everything hard and the cement has been cured. At this point, then we can remove the retractor, remove the patellar clamp, make a last search for cement, and again, more important areas become the lateral side, especially around the condyle and around the patellar tendon. Look in the notch, look superiorly. And then at this point, the important thing is that Bovie trick around the femur, anterior chamfer, all the way around to make sure that no synovium has gotten caught underneath that flange. And if we're happy with all of that, we're happy with our stability, we're happy that there's no more bone cement floating around. At this point, then we irrigate with another 500 cc's. And that's really fleshed out the knee. The last part is the closure, which I'm not going to go into in a lot of detail here, but that was just covered in a previous episode. So hopefully this takes all of the individual episodes where I really tried to get into the nitty gritty of why I do, and what I'm looking for, and what do we think about, and how do we affix this, or how do we prevent that. But this really walks you through all of those steps, and just kind of shows you the flow, but each individual step has a very specific reason and purpose, and each person knows what their goal or what their role is and what retractor they have and when and why, because this fits into that team's philosophy to make everything very efficient, which gets you through the case in an efficient manner, but at the same time having a plan so that you don't mistakenly forget a step or miss something or don't take out an osteophyte or do a certain release that may have a ultimate effect on the outcome. So thanks again for listening. If you haven't already, please subscribe. And if you know of a friend or a colleague that you think would enjoy this, please share this with them. And you've been listening to the Total Knee Tips and Pearls podcast. Until next time, I'm Adam Rosen. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.